The upfront trials that included Paloma 1 and Mona Lisa 2 and Monarch 3 primarily focused on enrolling postmenopausal patients who had not seen any prior therapy for their metastatic disease. They could have had prior therapy for their breast cancer in the adjuvant setting and then have gone at least a year prior to relapsing with their metastatic disease. But all those frontline trials did not allow women who had had any kind of prior therapy, and they focused on postmenopausal women. So that's the general criteria for those upfront trials. In contrast, the salvage trials that occurred in second-line therapy, such as Monarch 2 or with Paloma 3, allowed women who, in essence, were pre-treated for their metastatic disease and had seen a prior line of endocrine therapy and enrolling them onto fulvestrant plus a CDK4/6 inhibitor. One differentiating factor between the Paloma trial and the Monarch 2 study was that Paloma trial allowed patients to have at least one prior line of chemotherapy prior to entering, whereas Monarch 2 did not allow that to happen. So the populations were slightly different there, which may in part contribute to some of the differences that were observed for progression-free survival across the two trials. And so the final group of patients that were enrolled on the later studies were a mix of pre and peri and postmenopausal patients though as well. Whereas the first-line trials were only postmenopausal, some of the later salvage lines included women that were both pre- and perimenopausal, and we saw some of that data presented at ASCO with regards to Monarch 2 showing the efficacy in the pre- and perimenopausal subset of patients. For Mona Lisa 3, in essence, the main difference there, and that was the main distinguishing factor of the study, was that it allowed women who had failed or progressed on a prior line of endocrine therapy for their disease, but it also allowed women who were what we call de novo metastatic disease, and that was the main distinguishing factor of Mona Lisa 3 in comparison to the other studies, and that's a unique subset of patients that we were looking to get additional data on for the strategy of fulvestrant plus a CDK4/6 inhibitor.
The trials that have looked at endocrine therapy and CDK inhibitors were based on the line of therapy patients were receiving. In the first-line therapy, people were generally receiving aromatase inhibitors with, the trials used aromatase inhibitors with or without CDK4/6 inhibitors. And in the second line, they typically used fulvestrant plus or minus. But with the change in standards as to what one would use as the endocrine therapy in first line, now allowing both fulvestrant or aromatase inhibitor, maybe even favoring fulvestrant in patients who had never had hormonal therapy, the practice is evolving a little bit, and I think now many physicians are going to choose to use fulvestrant in the first line setting. And so the Mona Lisa 3 was a study that allowed fulvestrant in either first or second line settings. So I think the endocrine partner that we use now can be one of several. And so we do have some flexibility based on patients' preferences. Some patients may have issues with compliance. You may want to use fulvestrant in the first line setting. Or based on the Falcon data, someone that has, say, non-visceral disease where the benefit of fulvestrant over AI seemed to be the biggest, one might choose to use fulvestrant in the first line setting. And then finally, based on the Mona Lisa 7 data, one could even transition to tamoxifen if significant side effects are being seen with an aromatase inhibitor.
I think the data from FIRST and Falcon and Confirm should be considered, especially with the latest data that's been generated and presented here at ASCO, that the idea is if we know up front for certain subtypes of patients, particularly it appears those that have de novo metastatic disease, those with bone-only or non-visceral disease, and those patients that appear in general to have a more indolent biology or a slower growing biology may fare better when we start off with fulvestrant. That is an important management point in the treatment of hormone receptor positive metastatic breast cancer that we have to consider. So I think some physicians now are going to start having to integrate not only the patient's treatment history, but also hints about the biology of the cancer that they're faced with in terms of selecting the appropriate partner with a CDK4/6 inhibitor. Another important point I wanted to highlight, though, too, that I hadn't mentioned previously is that especially in patients who have seen a prior line of therapy, doing next-generation sequencing assays on patients in order to identify acquired ESR1 receptor mutations is going to be critical, because we have data from trials like SOPHIA with retrospective data that showed fulvestrant was more effective as a therapy in women who were known to harbor ESR1 mutations compared to an aromatase inhibitor.
When we're choosing which patients in whom to use a CDK4/6 inhibitor or which endocrine partner we should select, there are a number of factors we consider. Time to recurrence is kind of a nebulous factor because we're not really sure where the cutoff is. Is it 6 months from endocrine therapy in the adjuvant setting where we really think they're going to be resistant to that agent? Is it 12 months? Is it 24 months? Typically, we say if a patient's recurred within 12 months of being on an adjuvant AI, that we should consider them resistant. There's more recent data suggesting 2 years is an indicator of resistance versus sensitivity. More and more, we are using next-generation sequencing to look for markers of resistance, such as ESR1 mutations, which may help us determine whether we should be using fulvestrant versus an AI.